Assalamu alaikum. In today's lecture, we are going to master anti-Parkinsonian drugs. Following are the landmarks of my today's lecture. So let's get started. Our first landmark is what is Parkinson's disease? It's a chronic progressive neurodegenerative disorder that is characterized by bradykinesia. It means slowness in initiation and execution of movements, increased muscular tone, rigidity, tremors at rest, and gait changes. Coming towards the pathogenesis, first we have a clear-cut concept of dopaminergic neuropathic pathways. There are three dopaminergic pathways in our central nervous system. The first one is nigrostriatal pathway. It originates from substantia nigra and terminates in striatum. It controls the movement activation and suppression. The second pathway is mesolimbic pathway. It originates from ventral tegmental area and terminates in limbic structures. It controls cognitive functions and sensory perception. The third and last pathway is mesocortical pathway. It originates from ventral tegmental area to the cerebral cortex. It controls motivation and emotional response. Now we will treat out this problem. Main goal of treatment is to increase dopamine level and antagonize the excitatory effect of cholinergic neurons. This treatment can be achieved by four main classes of drugs. In first class of drug, we give levodopa, that is the precursor of dopamine. We can't give dopamine directly because it cannot cross the blood-brain barrier, while the levodopa can. Now, here is a problem with the levodopa. In periphery, some enzymes metabolize levodopa and convert it into some other products. For example, the enzyme dopa decarboxylase convert levodopa to dopamine, and another enzyme COMT convert levodopa to 3-O-methyl dopa. To prevent the peripheral metabolism, we give levodopa along with some other drugs. For example, carbidopa to inhibit dopa decarboxylase and entacapone to inhibit COMT enzyme. Now, inside our central nervous system, dopamine is synthesized from levodopa and is packed inside the vesicles. On the arrival of action potential, dopamine is released and bind to postsynaptic dopaminergic receptors. There are different types of dopamine receptors. To understand the classification of dopaminergic receptors, you have to watch my separate video. After binding to postsynaptic receptors, extra dopamine is taken back and get metabolized by monoamine oxidase enzymes and catechol O-methyl transferase enzymes. Monoamine oxidase enzymes, MAOB in short, is a mitochondrial enzyme that converts the dopamine into DOPAC, and COMT converts the dopamine into 3-methyl tyrosine. To inhibit its metabolism, we use MAOB inhibitors, for example, selegiline and risogiline, and COMT inhibitors, for example, tolcapone. In third class of drugs, we use direct dopamine agonists which bind to dopamine receptors and produce dopaminergic activity. For example, bromocriptine, pergolide, pramipexole, and ropinirole. Last but not the least, we use anti-muscarinic drugs. As we know that decreased dopamine levels increase the acetylcholine level inside the brain and produce cholinergic side effects. So by using anti-muscarinic drugs, we can help to improve the symptoms of Parkinson's disease. For example, benzotropine, amantadine, and trihexyphenidyl. Now let's discuss the side effects of anti-Parkinsonian drugs. Levodopa along with the carbidopa causes GIT upsets, dyskinesia, behavioral effects, and on-off phenomena. Monoamine oxidase inhibitors, if used along with tricyclic antidepressants and selective serotonin reuptake inhibitors, it causes serotonin syndrome. Dopamine agonist causes nausea, constipation, orthostatic hypotension, dyskinesia, and the mental disturbances. In the last, antimuscarinic drugs, they causes atropine-like effects. For example, blurring, dry mouth, urinary retention, and the enlarged pupil. That's the whole summary of today's lecture. Hope you enjoyed this video. See you in next one.